Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Incontinence and erectile dysfunction are two conditions that men may face after surgery for prostate cancer. Urologist Benjamin Cedars is here to discuss these side effects and their remedies. Welcome to the Informed Patient, Dr. Cedars.
Thank you so much for having me.
Let's start with incontinence. What is incontinence?
So incontinence, in simple terms, is the leakage of urine when you don't want or intend to. And the International Continence Society defines it specifically as involuntary loss of urine during the bladder storage phase. And we typically divide urination into two phases. There's the storage or filling phase, and that's when the bladder is relaxed. And then the emptying or voiding phase when the bladder needs to contract to expel urine.
And I've heard there's stress incontinence and urgency incontinence. What is the difference?
Yes, so stress incontinence is leakage with physical exertion, like heavy lifting or changing positions from sitting to standing, or another stress such as coughing, laughing, or sneezing. And then urge incontinence is associated with the sensation of urgency, so a strong, sudden need to urinate. And you can have other forms, and you can even have both of these at the same time.
I was going to ask, so one is not exclusive of the other. You could have both at the same time.
That's right. We call it mixed incontinence, usually with one or the other being predominant. And we may need to tease out what's happening with the bladder using additional tests and then address what's most bothersome, and one or both may need to be treated.
Now, how common is incontinence for men after the surgical removal of the prostate?
So it is very common in the immediate postoperative period for those first 3 months after surgery, once the catheter is removed, which is usually after 1 week. And then it may continue to improve for the first year after surgery. And at 1 year, use of at least one pad per day is anywhere from 10 to more than 40%, depending on the study that you look at. And more severe incontinence, meaning several pads or more per day, affects a much smaller subset of men, usually only 3 to 5%. And those are the ones who are generally seeking treatment and even considering surgery to help treat it.
It might get better on its own over time?
That's right. It does tend to improve up to 12 months, but that initial period postoperatively, it's right after all of the insults to the bladder and urethra have occurred. And so that's when they're going to have the most severe leakage.
I know we're talking about surgery primarily, but does this also happen with radiation therapy for prostate cancer?
No, not typically. Radiation doesn't have the same effect on continence to the same degree that a radical prostatectomy does. It's not never, but it's unusual to have persistent incontinence. There's a trial called the PROTECT trial that looked at these outcomes and found that for radiation therapy at 6 months, the rate of incontinence was 5% compared to almost 50% in the prostatectomy group. And then at 6 years, the rate for radiation was 4% versus 17% compared to surgery. So you can see that in both cases, immediate and long-term radiation was better in terms of leakage, but that it did significantly improve in the prostatectomy group from 6 months to 6 years.
So with prostatectomy, why is incontinence a concern? Because I'm wondering, does the prostate play a role in maintaining continence?
Yes, it does. So surgery impacts continence in multiple ways. One, removing the prostate itself removes a barrier or resistance to leakage. There's also something called the internal urethral sphincter, which is a continuation of the bladder muscle. And that's what tends to provide the passive continuous continence, meaning, basically at rest, how do you prevent leakage? And that is necessarily injured by surgery. There are also a lot of support structures. There are ligaments, there are fascial planes, there are pelvic floor muscles that are either intentionally or unintentionally weakened or injured. And then there's the external urethral sphincter, which can be damaged and lead to intrinsic sphincter deficiency. And then that's on top of injury to nerves and blood vessels, changing the innervation and blood supply.
So there's more than one sphincter. You mentioned an internal and an external. It,
That's right.
is the internal inside the prostate?
It's a little confusing. It's not a sphincter in the way that we normally think about it, like a circular muscle structure. That's what we tend to more associate as the external urethral sphincter, which we're able to voluntarily contract and control. The internal sphincter really is a continuation of the bladder muscle from the bladder neck all the way to the membranous urethra. So it does run through the prostatic urethra. And then because it is inside the prostate, when we remove the prostate, you're taking away that tissue that is associated with the internal sphincter. So you can actually leave some of that tissue, but it's necessary to remove a good chunk of it for the surgery.
And you mentioned there'll be other tissue, nerves that will be cut or disturbed in some way during the surgery.
Yes.
Do those grow back?
So they can, and they may. There's some healing and there may be some regeneration of these nerves after surgery, but the impact on functional recovery in terms of urination and erections is limited, and there's still a lot of research that needs to be done there.
Is there anything that increases a man's chances that he'll have longer term incontinence? And if so, is there anything he can do to help reduce that risk before surgery?
There are, on the surgeon side, there are techniques that we employ to maximize the postoperative urinary and sexual function. And so patients can talk to their physician specifically about, are they doing any of these, or, what are the latest methods? And then there are also patient factors that can affect it. Some are under our control and some aren't. For example, older age is associated with worse functional outcomes. So 65 and older, we've seen those results will differ. And that may be due because the muscles, just as you get older, they're weaker. You have more fibrosis or scar tissue formation or atrophy of these structures. Higher BMI has been shown in some studies to lead to worse outcomes. And so weight loss with healthy diet and exercise may be beneficial on top of the other general health benefits from those activities. And then there's something called preoperative rehabilitation or prehab to learn how to strengthen the pelvic floor muscles. And that may help with the immediate outcomes in terms of leakage, but it hasn't really been shown to show sustained benefit beyond that first 3 months or so. But we can talk more about the physical therapy in the postoperative setting as well.
This is Upstate's The Informed Patient Podcast. I'm your host, Amber Smith. I'm talking with urologist Benjamin Cedars from Upstate Medical University. Let's talk about the treatments for incontinence. What is available after surgery?
So the good news is there are a lot of different options, and I like to talk about them in stages from least invasive and lowest risk to most invasive and highest risk. So to start, there's pelvic floor physical therapy, and that means strengthening the muscles that support the urethra and the sphincter. And some studies have shown benefits, others haven't shown such a big difference, but I think it's a safe and low-cost, non-invasive way for men to gain control, both figuratively and literally. And even though effectiveness will vary, studies, one, for example, showed a statistically significant difference at a bunch of different postoperative time points from 1 to 12 months. And that was substantial. So I do think it makes sense to talk to your urologist about trying this if you're experiencing this problem, because you may see improvement and not feel the need to have additional treatments done that may be more invasive.
And so that's physical therapy with a physical therapist who's specially trained in pelvic floor therapy.
That's right. And, they'll have you primarily focus on the external urethral sphincter that we mentioned and the levator ani muscles in the pelvic floor. Those are the primary contributors to continence after a prostatectomy, but they may also involve other structures like the core muscles that may help optimize the pelvic floor function. And they may employ biofeedback and things to make sure that you're isolating and strengthening these in the correct way. So if you're doing these exercises incorrectly, you're probably not going to see the benefit that we would hope you would get. Versus if you start with the specialist who shows you and make sure you're doing it right, then even once you're done seeing them, you can continue those exercises on your own.
So what else is available?
So there are still some other non-invasive options for patients who are a little more risk averse, or maybe their incontinence isn't as bothersome or severe. And so those include non-surgical devices such as external collection bags, or what we sometimes call a condom catheter, which is exactly as it sounds. It's a condom that you put on and it collects the urine into a bag. So rather than needing to wear pads that get wet and they can smell and they can be uncomfortable and then you have to dispose of them, you can have just a bag that when it gets full, you can go to the toilet, you can empty it and flush it down. And that may work well for some patients. One problem we face a lot with that one is they just have trouble keeping it on. It won't stay on, it doesn't fit right. And so it's sort of useless. But for some men, I've had them be extremely happy with it. Another are these external compression devices, sometimes called a Cunningham clamp, but there are different options. Some are almost like a clamp that snaps shut on the penis and urethra. And it's a soft clamp. I think it may make you recoil at first, but it's supposed to be comfortable enough that you could wear it for a few hours at a time. There are alternative versions of this that are Velcro and sort of circumferentially tighten and compress the urethra. Those are good in short bursts. So for men who are experiencing stress incontinence at the gym or doing yard work, or if they're going out for dinner with friends or family or a movie and they really don't want to leak during this short period of time, then that's a good time that they could wear this. But when they're at home, it's not something that they should be wearing 24/7. So making sure that there's skin is intact and there's no pain and things like that. So those can be effective for the right person. And then there are some more, and we start to get into the surgical options. One is called ProAct, which is 2 adjustable balloons that are inserted where the prostate used to be, and it provides compression on the urethra and bladder neck. And the nice thing about these is they can be adjusted in clinic by adding volume to those balloons until you reach the desired effect. And they have done some studies on this that show a cure rate, meaning 0 to 1 pad is about 60%, and 80% see at least 50% improvement. So it tends to work, and it can work well, but the nice thing is it balances the invasiveness and the risk with a shorter surgery. And then we start to get into some of the more invasive procedures. So a urethral sling is basically a hammock of mesh that we insert to help lift the urethra, and it improves the closure of the external urethral sphincter. So I like to think of it as a spotter at the gym, helping to lift a heavy weight. So you have to have some level or some ability to lift that weight. It's not going to do it all for you, but it can assist. And this is best for mild to moderate incontinence, so usually less than 5 pads per day. And the 3-year success rate for that is close to 70%, with another 20-something% improvement of at least 50%. So that's a little better success rate and maybe a little more invasive as well. And then lastly, we have the artificial urinary sphincter, which is the gold standard for us. It has the highest success rate, but it also has the most risk associated. These are mechanical devices. There's a circular cuff that goes around the urethra to mimic the sphincter, and it provides compression to prevent leakage. There's also a pump that's placed in the scrotum, and that's what the patient needs to squeeze to release the fluid in the cuff that then allows urine to leave. And then it slowly reinflates and provides the compression again on its own. So it is a mechanical device. You have to be able to manually have the dexterity to operate it. And you don't want to forget that it's there and try to pee through it, because that can be dangerous. These are all internal components, so that everything is inside the body, not external. And we generally see a success rate of over 90%. So it's important to talk with your doctor about the risks and benefits of all these options and see what would be right for you based on your priorities.
Well, it sounds like there are a lot of options, so that's good.
Yes, yes. you can start with the less invasive option. And, if it's not working, you can escalate that therapy. So that's another conversation to have.
Yeah, how common is erectile dysfunction for the men after surgery?
So it is common. And, there are different studies that show a range of outcomes, anywhere from 10 to almost 50% of men at 1 year. And that may improve slightly by up to 2 years. And it's reported that up to half of men may return to their baseline, but generally I counsel that that's not a goal that they will reach. And the best predictor for postoperative function is preoperative function. So we do see better outcomes in men who are younger, who already have good sexual function, and who receive bilateral nerve-sparing procedures. Other medical conditions like diabetes or vascular disease, poor physical conditioning, and smoking may also increase patients' risk of erectile dysfunction.
Bilateral nerve sparing surgery, is that a certain way that the operation has to be done?
Yeah, so nerve sparing is self-explanatory. It's basically trying not to injure the nerves that are running alongside the prostate and provide erections. So it does depend on certain factors, disease factors, whether it's possible for the surgeon to do this. And that means if there's extracapsular extension, meaning the cancer is really coming outside of the prostate, if it's at that exact location near where the nerves run, that's going to make it less safe for the surgeon to spare the nerves. Because most important is we get all the cancer out, not that we spare the cancer. So it's important to have that discussion and really understand before you go into surgery what's going to be possible for you. And it is nice to know, though, even if one side is running close to that, often you can do a one-sided nerve spare. So there are options there.
Well, let's talk about treatment options. Do medications like Viagra or Cialis work after prostatectomy?
Yes. So we employ those medications very frequently. Sometimes they're used reflexively in the immediate postoperative period as well, just to get blood flowing to that surgical area and help with healing. And then once we sort of understand what patient's function is, then we'll also use them as treatment for that. So these are phosphodiesterase 5 inhibitors. And essentially what they do is they increase blood flow to the penis. And it will depend on patient factors, how they'll respond to these. Men who had nerve sparing tend to do a lot better with these medications than those who didn't. There are multiple different agents in this class of medications. So Viagra, Cialis, Levitra, Stendra, these are all options. They tend to have different rates of onset, maybe different side effects, certainly different costs. So you just have to see what your insurance is and talk it through with your provider.
But they could be options for all men, or are there some men where this would not be an option?
There are certain contraindications to taking these medications. So one of the big ones is taking nitrates, which some men take for a history of cardiac disease. And that's because it can cause severe low blood pressure that can be dangerous. But then there are some other nuanced takes about alpha blockers, which many men are on, like tamsulosin or prazosin. Those may also be contraindicated depending on which of the PDE5 inhibitors you're taking. There are some common side effects to all of them that are not contraindications, but you may experience headaches, flushing, dizziness, some GI symptoms. Viagra is known to cause impaired vision, and that's why maybe you've heard pilots aren't supposed to take Viagra, and it causes changes in blue vision. And Cialis can also cause muscle pains.
So aside from the medications, are there other options?
Yes. So similarly to incontinence, there's sort of an escalating ladder of therapies. The oral medications we just discussed fall on that. There's also things like a vacuum erection device, which uses manual pressure suction to increase blood flow to the penis. And you can combine that with an occlusive ring at the base of the penis to prevent blood from escaping. And this device also may help regain lost length after surgery, which some men will experience. Usually it's small, 1 to 2 centimeters on average, but it can be regained in a combination with the vacuum erection device and a PDE5 inhibitor. Some men do find these devices uncomfortable or not effective, so best to test it out and see what works for you. Then there are injection medications. There are different formulations, and they tend to be stronger than the oral agents. They tend to work quickly, but you do have to be careful. Use the correct dosages. Don't increase them on your own because there's a risk of priapism, which is an erection lasting too long. That can be an emergency. There are other side effects. The main ones are pain from the injections, bruising, scar tissue formations at the injection site. And then there's just the psychological barrier of having to use a needle at the base of the penis. So all of that will be discussed. And usually we do a trial of the injection by a nurse or by the provider in the clinic to make sure you understand how to do it safely, see what the response is, and then you can then later try it again at home.
Are there prosthetics that are recommended?
Yes, so there are prosthetics. There's two main types. There are malleable or semi-rigid implants and inflatable implants. So the malleable ones are easier to use. They're lower risk. They basically are one size 100% of the time with enough rigidity for sexual activity. So it does mean even when you're not using it for sexual activity, it will still be a little firm and a little larger. The inflatable version achieves more quote unquote natural erections because there's a flaccid and an erect state. So it's balloons that we place along the shaft of the penis. And similar to the AUS, you have to manually squeeze a pump in the scrotum to inflate those balloons. And then the penis will stay hard as long as you want for activity, and then it can be deflated. The nice thing about these, they have very good success rates. They have high patient and partner satisfaction. You still maintain sensation and pleasure and orgasm. And, you can imagine men who have reached this point are very unhappy, right? They're not able to have intercourse. They're not able to achieve erections. It can be very emasculating. And now you are able to give them a definitive cure to get erections again. It is important to know that you can't go back to natural erections after one of these devices. But usually men who reach this point can't have those erections anyway. And then there are risks to these devices, mechanical failure, need for revision over time. But generally, again, they are very successful and they can last a long time.
But it's another surgery to have those implanted?
Yes, it is a totally separate surgery. And it depends on who your surgeon is. Sometimes you go home the same day. Sometimes you stay overnight. And you'll get all of the necessary teaching about how to take care of yourself and what the healing process looks like.
Well, Dr. Cedars, I thank you so much for making time for this interview.
Yes, thank you so much for having me.
My guest has been Dr. Benjamin Cedars, a fellow in urology at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Spotify, Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.